I'm Rachel Patzer. I'm on the CEoT Planning Committee. Welcome to the Lunch Symposium, Biomarkers for Kidney and Liver Transplant, Research Pathway to Personalizing Medicine, sponsored by Eurofins Transplant Diagnostics. So on behalf of the AST, I'd like to thank Eurofins for their continued support of the CEoT meeting. Please welcome the symposium moderator, Leslie Stack, Medical Science Liaison at Transplant Genomics, to the stage.
Thank you very much. Thanks all for joining. I know it's the first beginning of the CEoT conference, so we really are appreciative of you coming to learn from our wonderful panel of speakers over here. We have Dr. Ram Petty, who is the Director of Kidney Transplant Clinical Research at California Pacific Medical Center, who'll be talking a bit about TrueGraf and immunosuppression minimization in low-risk kidney transplant patients. Dr. Steve Kleibacher, who's our Chief Scientific Officer for Eurofins Clinical Diagnostics. Dr. Danielle Leisure, one of the medical science liaisons for our company, as well as Dr. James Fleming, the Director of Clinical Trials and Research, who will give you a little bit more information about what our company is doing in the research space. So without further ado, Dr. Ram Petty, please join.
Thank you very much, and I would like to thank the organizers and the Transplant Genomics for asking me to kick off with this presentation. So we're going to talk about immunosuppression management in renal transplant recipients with the TrueGraf study at our center. So if we look at the immunosuppression post-transplant, currently there is no standard test that measures the adequacy of immunosuppression. The monitoring strategies that we use now are all reactive, such as serum creatinine. We intervene if the creatinine goes up, or if there is creatinine goes up, or if there is an infection, then we titrate the immunosuppression, and we also get a donor-specific antibody. Only after it goes up, we intervene, or if there is a new donor-specific antibody. And surveillance biopsies are proactive, but they are invasive, infrequent, and not standard of care at majority of the centers. So, the question that always used to come up is there a way to manage immunosuppression non-invasively? So if you look at the immunosuppression, the way we use the top triangle, when somebody gets a kidney transplant or any transplant really, we use induction and higher doses of immunosuppression, and as time goes on, we decrease the immunosuppression. But what is not so obvious is the immunosuppression is cumulative, and when we as time goes on, somebody who's 10 years out or on their second transplant, they will have a lot of immunosuppression exposed to. And if we cut down the immunosuppression at any time point, maybe it might be beneficial to those patients. And kidney transplant recipients are considered high risk for acute rejection within the first 90 days of transplant, and that's why we use induction immunosuppression. And this is recent, within the last 4 years, from SRTR data, and more than 95% of patients receive some form of induction, either an IL-2 or a T-cell depleting agent, and the rejection rates are very, very low. Really, about 8 to 10%, or even less than 10% at most patients, at most centers. Having said that, one of the concerns we always have is about subclinical rejection and how it is associated with worse outcomes. And there have been many, many studies which have looked at the protocol biopsies and the treatment of subclinical rejection. And these are some of the studies that we have highlighted here. And clearly, if you diagnose subclinical rejection and treat subclinical rejection, in the long term, it has been shown to improve the graft survival. And of course, we all treat clinical antibody-mediated rejection or clinical acute cellular rejection. The thing we don't really know. It possibly is that, the subclinical rejection may eventually become clinical rejection. And if you treat at the clinical rejection stage, which is shown in the panel on the right, the long-term outcome is much poor than intervening at the stage of the subclinical rejection. And so this cartoon actually highlights what actually happens. So you have multiple episodes of subclinical rejection and clinical acute rejection there. And over time, if they are treated or untreated, there is more of the interstitial fibrosis, tubular atrophy, and eventually there is graft dysfunction. So, the time to intervene would be when there is subclinical or early clinical rejection. This is the CEoT 8 trial. It's multiple centers were involved in this study. And if you look at the subclinical rejection incidence, about 20% of the biopsies had shown acute rejection, subclinical rejection. So on the flip side is that 4 out of 5 patients who have had a protocol biopsy will not have any intervention. So there are a lot of biopsies done to find out or diagnose a few subclinical rejections. So kidney transplant patients, the way we use immunosuppression is pretty much one size fits all, and only if they have a problem, we cut down on the immunosuppression or go up on the immunosuppression. And almost most patients would have some form of an infection either earlier on or later on. And one of the things that we are struggling with these days is the BK virus infection, and the incidence of BK viremia sadly is much higher than that of the acute rejection. And we're working on a paper, and it's somewhere between 15 to 20% of the patients will have BK viremia, and when you cut down the immunosuppression, about 5% of the patients have BK virus nephropathy. So, and also it looks like even just having a BK viremia, even if you do not have viral nephropathy, there is a long-term consequence of that. So there is some benefits of decreasing immunosuppression earlier on. And not only the infections, but we see all of these other complications, liver disease, malignancies, and coronary artery disease may or may not be related to the immunosuppression, but decreasing the immunosuppression may benefit some of those adverse events. So this is looking at a very, very high level. The way acute rejection starts is that there is some form of trigger that causes antigen presentation, and subsequently you have immune activation, cell injury, and that is the subclinical rejection, and then subsequently you have clinical graft injury. That's where you do a kidney biopsy, or you see that elevation in serum creatinine levels. So if you look at this cartoon here, the gene expression testing or profiling studies would actually may hopefully help you diagnose a problem at the level of the immune activation, and subsequently you may intervene. The cell-free DNA is probably diagnosing a cell injury at this stage, although there is some emerging data that presence of a donor-specific antibody may increase the levels of the cell-free DNA, and this is where majority of us are intervening at this point. So, TrueGraph. So, TrueGraph is a gene expression profiling study. So basically what it does is it looks at the gene expression profile of patients who in the peripheral blood cells, and of somebody who has immune system quiescence, and it differentiates those with patients who have immune activation or who may be at risk of having a rejection. And this is in patients who have stable graft function. So the gene expression profile test is designed when they looked at the gene expression of two subsets of patients, one with biopsy-confirmed normal histology, and another set is biopsy-confirmed subclinical rejection. And I'm told there are like about 120 genes they look at. And when I get the report of the TrueGraph test, it is a binary result. Sorry. It's a binary result. Basically, I get either a TX or a non-TX. Whereas a not TX means that there is not transplant excellent, which is a positive test. That means there is immune activation. But if the TX is it's a negative test and there is no immune activation, that has a high negative predictive. The test has a high negative predictive value. So if you have, this has been shown in earlier studies, and it's all been reported, and if you have a TX, there is a 85 to 90% chance that there is no immune activation. So based on this information, we conceived this study with the immunosuppression management based on the TrueGraph test. And this was actually something we thought of. This is a study that we started doing before the COVID, and things kind of got delayed by about 2.5 to 3 years, and we started actually patient recruitment subsequent to COVID. Once all of the things were almost back to normal. So in this study, we are taking patients who are males or females, more adult patients who have the ability to understand and give an informed consent, and there could be a primary deceased or a primary living donor recipient, and are high immunological risk for an acute rejection. We define the high immunological risk or low immunological risk, high immunological are excluded. The low immunological risk for acute rejection are somebody who have a CPRA level of less than 50, no DSA, and non-African American recipients. And we take the deceased donor kidneys. We only take kidneys or only recruit patients who have a KDPI of less than 50%. That has been the reason for the slow recruitment, finding kidneys less than 50% going into patients who have CPRA less than 50%. And the exclusion criteria are standard exclusion criteria for any study, and these are previous recipients of the previous transplant. We don't do any HIV positive patients at our center. Hepatitis B, C, PCR positive patients, patients on corticosteroids at the time of transplant because we want to eliminate the steroids, and then patients who have leukopenia or thrombocytopenia and will not be able to receive thymoglobulin are excluded from the study. So what we do is we take patients who are at low risk for a kidney transplant and then approach the patients before their transplant or immediately after transplant and ask them whether they're interested in participating in the study. And then once if they consent, they will receive thymoglobulin induction, generally about 3 to 3.5 milligrams per kg body weight, but at least 3 milligrams. That is a standard protocol. And then we plan on corticosteroid withdrawal by 30 days post-transplant. We follow their labs weekly, and at 90 days post-transplant, we look at whether they will meet the inclusion-exclusion criteria of part 2 of the study. We'll show in the next slide. And then they will continue with the part 2 of the study. If they don't meet the inclusion-exclusion criteria, they're done. They don't participate in the study anymore. And the inclusion-exclusion criteria for the part 2 of the study are they should have a stable creatinine with the eGFR of greater than 45. They should be over 90 days post-transplant. They should be off steroids and have received thymoglobulin of greater than 3 milligrams per kg. And then exclusion criteria, if they have BK virus, any significant BK viremia of greater than 10,000, if they have proteinuria of greater than a gram per gram of creatinine, and if they have any acute rejection, any grade, before day 90, they are excluded as well from part 2 of the study. So this is more a schema of the study design. At the part 2, patient randomized in it. And patients who are meet the inclusion-exclusion criteria for the part 2, they are randomized in a 2-to-1 fashion. 2 patients go to the standard, patients go to the study group, and 1 patient goes to the control group. The patients in the study group, they get the true graft testing at 3, 4, 5, 6, 7, 8, 9, and 12 months post-transplant, and we get the results in real time within 24 to 48 hours after we send off the blood sample. And then between month 3 and if they have a TX and no immune activation, between month 3 and 6, we slowly wean down on the mycophenolate. And if they continue to have TX, we cut down on the target, tacrolimus target, to between 3 to 6. And if they have a not TX consistently, we do a biopsy or otherwise other monitoring. And patients in the control group also get the testing at the same time, but the results are not run in real time. The transplant genomics have the blood samples, and they may have run the results. I don't know. I am blinded to the results. Or they may run the results after the study completion. And the immunosuppression management in these patients will be a standard of care. So this is the schedule of events. It is pretty involved study. Just move on to the next one. So currently we have 51 patients enrolled in the study. We plan to, our enrollment is 75, and 50 go to the study group and 25 to the control group. And right now we have 25 in 30, sorry. Right now we have 37 patients completed at least 3 months. And then in the study arm, there are 25 patients, control arm 12 patients. One of the patients did not want to be in the control arm, and he withdrew consent. So next few slides, we're going to be 25 and 11 patients you're going to see. Awaiting randomizations who are between 1 and 3 months post-transplant are 12 patients. 2 of the patients, one who had arthritis and previously was taking NSAIDs, and he wanted to be on steroids after post-transplant, and he was excluded, and also was another patient who had an acute cellular rejection. And 19 patients have completed 12 months, and I think 6, I think, 15 and, 13 and 6, I think, are in the study and the control group. We'll see that in a minute. So this is the baseline data at 3 months post-transplant, and we had 25 patients randomized to the study arm, 11 patients to the control arm, and as you can see, they are very similar. About a third of them have living donors, almost two-thirds deceased donor, and they are pretty similar in the control and the study group, and the renal function is also comparable. And we have to date enrolled 51 patients and 25 patients in the study group. The transplant genomics have processed 152 samples in these study group, and the interesting data point here is that 90% of the results, or 89 to 90% of the results, come back as TX, which is not surprising because these are low immunological risk group. And the 10 patients have had 10 out of 25 patients have had at least one test which was reported as non-TX, and there was only one patient who we'll talk about more, who had consequent non-TX at month 3, month 4, month 5 post-transplant. And these are the test samples that we sent to transplant genomics at different time points, and approximately 90% of them will be TX. At 7 months there is a 75%, I don't really know if this is a signal for something or it's just a small patient population, because this is when before 6 months is when their MMF goes from 1,000 to 500 BID, 1,000 BID to 500 BID. So that's something I need to keep an eye on. And this is the results at 3 months post-transplant. We have 25 patients in the study control, and the renal function is comparable. The tacrolimus levels are comparable, and their mycophenolate at 3 months is comparable in both groups. And this is at 6 months post-transplant. Their renal function, as you can see here, the creatinine of 1.19 versus 1.26 is comparable, and their tacrolimus levels are comparable, but we are beginning to see a decrease in their mycophenolate dosing from 1,500, that is before the 6 months, they have gone to like either 500 and 1,000 or 750 BID. And then at 9 months, they have a significant decrease in their MMF dose, and their tacrolimus levels are also at a lower trough levels compared to the control group. And once again, these are small patient numbers. This is at 12 months post-transplant. We have 13 patients completed the study in the study group and 6 in the control group, and there is a significant difference in their tacrolimus levels and the mycophenolate levels. These are the 24-hour, these are the 24 hours, they're on 500 BID, no steroids, and their trough levels are about 6. So we had one patient who was a patient with polycystic kidney disease. She's 57 years old, multiparous woman who had 29% deceased on a KDPI, deceased on transplant. And in the early post-transplant period, she had neutropenia, and we had to hold the MMF, and she only got tacrolimus for a few days. And then subsequently, at month 3, 4, and 5, her TrueGraph test came back as non-TX, and we did a DSA and also did a biopsy. The DSA, she has now a new class 1 DSA, which is a B HLA antigen, and also she had a biopsy with some interstitial infiltrate and minor tubulitis, but it did not meet the cutoff for the BAMF borderline. It was like about 5% of the interstitium was involved. So we increased her baseline immunosuppression, and from month 7 onwards, she has been TX, and she's 7, 8, and 9 have been TX with good graft function. A creatinine is still less than 1. So this is interesting that we now have possible interventions at different time points. You have the TrueGraph test now, which might tell you the immune quiescence versus immune activation at an earlier stage, and you also have the cell-free DNA testing that you can do, which may be able to pick up any problems with your graft also earlier on before there is a clinical injury. So when we started this study, we did not have the OmniGraph, which is a single test which can actually look at the whole spectrum. So, that is something that you will hear about more later on in this talk. So based on the preliminary results, we think that immunosuppression minimization in renal transplant patients may be feasible in patients with TrueGraph TX result. Thank you.
Sorry, that desert air is getting to me. So we are going to switch gears now, literally switching organs, and talk now about liver TrueGraft, or TrueGraft Liver, which is another product that we offer now. And I'm going to share this with Dr. Kleibecker, and we're going to delve into liver transplant a little bit. I don't know what's happening now. Cannot advance. There we go. Okay, so wanted to start first with just the current state of liver transplant. Take a look at where we are, 2020 with our most recent OPTN report. Despite COVID, there were the most liver transplants done in that year, about 9,000. There are 142 transplant centers that are currently doing liver transplants, and per the summary of the report, graft and patient survival continue to improve. And this is something that we think about with liver transplant, that things are really getting better. And on the graph on the left, you can see that one-year outcomes after liver transplant have remarkably improved over the decades. So you can see that, we're up to 92% one-year survival. What this group did was they looked at 111,000 liver transplant patients. Of those who lived to 1 year, what did their outcomes look like after that 1 year? And you can see based on the decade and based on the era, it's a pretty straight line. So our outcomes are improving because our first-year outcomes are improving. But when you actually look at what's happening after that, we haven't made very good progress. So what's going on with these patients? Well, a lot of them are dying from kind of our big four. A lot of those are going to be related to cancer and infection as our primary causes of death. And then we also have graft failure, which is often not rejection-related graft failure, along with cardiovascular complications. We have this big bucket of multiple and inconclusive causes of mortality, but really these are the big four. And you can see that they're happening really early after transplant, up to about 5 years, but cancer is our biggest one, and there are some things that we hope are going to improve with that, but really, what is this all a relation to? It's related to over-immunosuppression. So we know that. What we also think about after liver transplant, or when we're going into liver transplant, is what are their kidneys doing? And so what we know now, when you look at on multivariate analysis, the single greatest impact for mortality is what the baseline GFR is. So I want that to sink in. When you account for all other things, all of these things down here at the bottom accounted for, it's that baseline kidney function that is the single greatest impact. So we always know and we think about this, right? But we have the data to tell us that the lower the GFR, the worse they do. So a lot of times people are taking that into consideration, right? You're often adjusting your immunosuppression, taking their kidney function into account, and lowering the CNI. Well, not only does the baseline renal function matter, but also the rate of decline of renal function matters. So this group looked at specifically their Northwestern data, 670 patients, and categorized them on a rate of decline post-liver transplant. What you'll see here that's very interesting is this black group that started off normal but then had a rate of decline that was pretty marked. Really, though, ending up at a GFR of about 50 to 60, so a patient population you probably wouldn't be overly concerned about because they're still relatively stable. They had a very significantly higher risk of one-year all-cause mortality. So not only does the baseline kidney function matter, but what is happening after the transplant matters as well. So the kidneys we know are important. So what do we do about this? Well, the goal with immunosuppression after liver transplant is really preserve renal function, reduce immunosuppression. There are some various considerations you can take with the patient if they have underlying metabolic syndrome, obesity, diabetes, hypertension, hyperlipidemia, or malignancy. You can try to make adjustments for those things. Unfortunately, in the liver transplant population, all of those are going up. NASH is becoming the primary indication for liver transplant, so all of these comorbidities are just going to be greater. And then all patients should be considered for immunosuppression minimization. There are a few exceptions that are listed in the guidelines, which obviously makes sense. So a steroid-resistant rejection, history of AMR, or someone with an immune-mediated etiology of liver disease. Those are pretty much the only patients in the liver world that aren't classified for immunosuppression reduction. So unfortunately, what this looks like is a little bit of trial and error, where you just have to kind of dare them to reject. So you reduce the immunosuppression gradually, you watch for a rise in LFTs, you react to those LFTs, you go back to what you did last time. If they remain elevated, you biopsy them. If you found rejection, you treat it. In general, that is considered, the standard of care for liver transplant. And most people don't think that rejection really matters per se, but it does matter. So a single episode of biopsy-proven acute rejection after liver transplant is a predictor of mortality and graft failure for these patients. So this data on the left is 45,000 patients from SRTR. You can see, regardless of the timing of biopsy-proven rejection, no biopsy-proven rejections on the bottom. All of these other are rejections that occurred at various time points, 0 to 6, 6 to 12, and greater than 12 months after. What is also interesting is that the single greatest risk is within that first year after the rejection. So this is where you have a 2 to 4 times higher risk of mortality. So that kind of tells us not only is there that risk in that first year, but the risk continues after a year as well. So maybe it's time to adjust the approach to managing liver transplant patients and how we treat rejection. We know that a single episode of biopsy-proven rejection affects mortality and graft failure. The older data, this wasn't necessarily the case. It showed poor outcomes were only in patients with chronic rejection or those who were refractory to your rejection treatment. Unfortunately, patients are much older, sicker, and have more comorbidities now at liver transplant. So not only is the rejection affecting the graft itself, but those medicines you're using to treat the rejection are also going to put that patient at a higher risk for complications. This data has specifically held up in more recent years. So this group went back and looked at 2010 to 2019 data, separated HCV patients out to really see what things look like in the, when we look at the current state of liver transplants without the HCV patients. And you can see that it still holds. So non-HCV patients still have that risk of mortality and graft failure, which does represent our current liver transplant population. So all of these things are being balanced by physicians as they're trying to manage a liver transplant patient. You're trying to prevent malignancy, infection, metabolic syndrome, cardiovascular disease, chronic kidney disease, and graft failure and rejection. It's really a balancing act. You have to balance all of these things and just kind of hope for the best for your patients. The current tools in the toolbox aren't very great. We have LFTs like we talked about. You can monitor immunosuppression levels. We all know how fun tacrolimus levels can be to monitor. Surveillance biopsies, I probably could get no hands held to tell me how many places are doing surveillance biopsies in their liver transplant population. It's probably none. You can just watch them very closely, watch for changes, do cancer screenings, watch for viruses, and maybe check donor-specific antibodies. But really, it's not a very strong toolbox. And I'm going to bring Dr. Kleibecker up to talk to you about what I think is a very cool new tool that you guys can add to your toolbox.
Okay, thanks, Danielle. You did a great job of setting me up for success here. We'll see if I can get it across the goal line. So I'll talk a little bit about the science and some of the publications behind true graft liver. The idea is that this can measure differentially expressed genes in the blood and compare patients who do and do not have rejection, and it will allow confirmation of that immune quiescent state. So we really see this as a combination, a tool in the toolbox, as Danielle mentioned, to include the liver function test as well as the therapeutic drug monitoring for immunosuppressives and other standards of care that you're currently practicing with your patients. The goal here, I guess the strength of TrueGraph is that it can be non-invasive, so it does avoid the biopsy need at times because of the strong correlation with the results. So what is TrueGraph gene expression assay? This is a test that assesses the immune response. So a very simple method in principle, but of course it's always more challenging to carry out in the lab. Essentially we extract RNA from whole blood and measure the amount of gene expression through PCR or other molecular methods, and it differentiates peripheral blood genes that are high upregulated or downregulated in a rejection state versus those that are from patients with healthy allograft function. You get a binary result, as was mentioned with the kidney TrueGraph test. Negative indicates the non-AR or the desired state, the good state. A positive result indicates acute rejection. And the idea is really that you can use this as a tool for optimizing the immune suppression therapy. How did we get here? So just a broad overview of the pathway to discovering a biomarker test. Starts with a discovery cohort. These are typically patients in a study that have samples collected at regular intervals. I'll show you some of the details behind that in a moment. But the initial step is to identify candidate genes, a gene set, if you will, that clearly differentiates patients with and without rejection. Then there's some advanced bioinformatics, typically machine learning is used at this stage to train an algorithm that helps distinguish these two clinical phenotypes in this case. After the discovery process, there's a validation process where we go into a second, ideally a diverse cohort, to see if our hypothesis held up, if we can still distinguish the two patient populations. And then we can ask really interesting clinical questions, the stage we're at now. For example, with serial monitoring, can we detect preclinical rejection before there's graft dysfunction and elevation of the LFTs? Can gene expression be used to guide or taper the immunosuppression regimens, and does gene expression change after successful treatment? So I'll show you a little bit of results from that in a few minutes. First, about the study that was used to do the discovery and the validation. Two cohorts really, one from Northwestern, a single center study, collected from 2010 to 15, about 129 patients. Probably the main difference between this cohort and then the CEoT 14 is that the CEoT 14 group was multi-center, and there was serial sampling in the CEoT 14 study, but not serial sampling with Northwestern set, and then there was also sampling after episodes of acute rejection to assess the ability to bring the values back to baseline. So I'll talk about a few phenotypes in the next few slides. First, as we define acute rejection, these are patients with abnormal liver function tests and central pathology that determines the BAMP score for the rejection index of greater than 3. And then the next group is the acute dysfunction non-rejection. These also have abnormal liver tests, but central pathology determines that it's a non-acute rejection phenotype, so something that's not related to rejection. You can see the examples there: steatohepatitis, cholestasis, ischemia, other problems like that. Then the third group is a stable graft function. These have normal liver function tests for at least 6 months. You can see some of the values there that were used in the definition for this study. This was published in 2022, by the way, from Levitsky. And then there's the non-acute rejection, the non-AR. This is actually a combination of the ADNR, the acute dysfunction non-rejection, and the patients with normal liver function tests, or sometimes we'll call those TX, for transplant excellence. So a few more details about the discovery. Again, we merged the data from the Northwestern and CEoT trials into a 70-30 split, 70% used for discovery, 30% used for validation. And then for the CEoT 14 patients, we were able to evaluate the trends both before and after biopsy-proven rejection because we did allow serial sampling. You can see from the graph on the right that most of the patients were this non-AR, either ADNR or the stable graft function. 30% of the 73% were ADNR, and then the remainder were stable graft function. And 27% of the patients had acute rejection. I'm sorry, 27% of the phenotypes had acute rejection. So again, from this 2022 paper, I'm sure you're familiar with this and probably have read the paper, but essentially the performance characteristics are shown in the graph on the right. The accuracy, discovery and validation, pretty similar, 78 and 72%, sensitivity around 70%, specificity around 80% for the discovery and 73% for validation. The real strength, though, is in that lower row, the negative predictive value, or NPV. So these would be patients patients with the non-AR or the stable function phenotype, the ability of the test to distinguish those from the AR was the strongest. I didn't mention it before, but this was based upon a 59 gene set that was used in the analysis. And so this is probably one of the most important parts of the paper, I think, in that you can see the timing here. So the graph that I'm showing on the left here, these are the scores for the AR versus non-AR, and the top line you can see is increasing. And the arrow below the liver function shows that the liver function values increased at around 30 days. They were above baseline, clearly above baseline at about 30 days prior to rejection. But the important point is that the gene expression test showed a positive result up to 70 days prior to rejection. So this is one of the key findings, is that gene expression can detect this non-immune quiescent state in advance of the dysfunction shown by the liver function test. And then a second important point is pre and post diagnosis and obviously treatment of AR. So pre-AR, the graph on the right, you can see the value, the score from the gene expression test is increasing. Then post-AR, after treatment, you can see the value decreasing. So it is a treatment response biomarker as well, and return to negative as soon as 3 months following acute rejection. So that's all I'll talk about for the science. I'll turn it over to James now for the clinical trials.
Thank you, Steve. And thanks, everybody, for staying for my part. Not only did you grab some lunch, but you're staying towards the end, and I applaud that. So I actually really enjoy my part of this talk, because I get to talk about, much like Dr. Petty gets to talk about, what are we going to do with these biomarkers that we have. So, we all know what the problems that we're having, and we get to see how these tests are developing. But then the question comes up: well, how do we use these? How do we use these to address the problems that we face on a day-to-day basis? And so, I get to deal a little bit in a mix between hopes and dreams, and then reality on what happens with the studies. So I'm going to start off with kidney. We're going to pivot back to kidney clinical trials, because this is where the vast majority of our clinical trials are. And then we'll go back into the liver one for those of you here that are excited about that. So the first one I want to talk about is one that's been ongoing for a few years now. Excuse me. The TRULO study. Many of the people probably in this room have been involved with this, but it was our first large-scale multi-center trial. We had 52 centers in it now. We are targeting 2,400 people for enrollment. And the main goal of this was to evaluate long-term outcomes in patients monitored with TrueGraph and then TRACK. And not only long-term outcomes, but we also get to see how the tests work in patients a little bit later post-transplant. A lot of the data in the development and validation were patients within 2 years post-transplant, whereas the median time post-transplant in the TRULO is around 2.5 years when they actually enter the study. And so then with 2 years of follow-up, you see we're getting a little bit closer to 5 years post-transplant. So I'll give you an update on where this study stands now. Right now we have almost 2,000 subjects enrolled out of the 2,400, so we're really getting close to wrapping up enrollment and then entering the follow-up phase. We did a data cut for a planned interim analysis where we had 538 subjects that had 12 months of follow-up. And we have a lot of data to share on that. I can't show it all to you guys right now because it is going to be presented as abstracts at ATC. But some of the abstracts that you can look forward to be seeing there, the relationship between omnigraph results and renal function, and slope and change renal function over time as they're being monitored, perceived clinical utility by investigators, and then the relationship between gene expression and donor-derived cell-free DNA tests. Essentially, two tests, do you need both of them? Are they different things? So really excited to present, have you get to see that data at ATC. So the next thing is that we wanted to get a little bit more into the problems that we face as, that you face as clinicians, things that I used to face when I was in clinical practice, in trying to figure out how to take care of the many problems that we run into. So we talk a lot about, there's, reducing rejection rates. We've seen some improvement in graft half-life over time, not nearly as much as we've seen an improvement in rejections, but we're still not doing great. More than half of patients at a year post-transplant are in stage 3 CKD, and we know when we get to stage 3B CKD or lower, those are the patients that have the highest odds of graft loss at a year. And so when you see these patients a year out and they may be stable, but they don't have ideal kidney function, the question always comes up, what is there something I can do about this? Is there something mutable that I can try to prevent the progression of this slow decline into kidney failure? It's a big question. We also know that more than half of patients now, at all time points post-transplant, are dying with a functioning allograft. So it's not just losing the graft because of immunologic causes, but it's because of the comorbidities that we are either create or exacerbate by providing the immunosuppressive medications that we give them. We also know that adverse drug events play a significant impact on both graft and patient survival. This study from the Medical University of South Carolina showed that patients that had readmissions caused by an adverse drug event had significantly worse both patient and graft survival compared to patients that never had a readmission or patients that had a readmission that was not considered related to adverse drug events. And so we developed a study to try to address some of these clinical conundrums, these medication side effects, as well as what to do in patients that don't have ideal kidney function. So we're really excited to announce the Clarity trial that just started up about a week ago. We had our first sites activated. This is going to be a 3-year study of a similar size to the Trulo study. 50 transplant centers are anticipated to be involved with it. And we're going to be evaluating whether having biomarkers available to help make decisions in these patients that have medication side effects as well as poor kidney function can improve renal function over time. So one of the tools that we are going to be providing to these clinicians is patient-reported side effects. One of the things that we've identified is that there's a big discrepancy between how many patients feel like they're having significant side effects compared to how many clinicians, clinicians think have side effects. And there's been studies out there to show that it's really the patient's perspective that's closely related to non-adherence and closely related to then the future downfall of the graft, right? And so patients in this study are going to have the opportunity to provide information on what their side effects they're experiencing in between clinic visits, as well as how important it is to them. I know many of you guys probably have seen patients that they may have tremors or even diarrhea, and you ask them how much they're having it. I have it all the time. That's horrible. They're like, well, it doesn't really bother me, right? So it's really the perspective of the patient that matters, how important they feel about it. So then that data is going to be provided to the clinicians. Clinicians then can look at this patient, and the diagram in the middle is very biomarker focused, but really the way that we would anticipate clinicians using this is that you see a patient, they either have not ideal kidney function or they have a reported side effect based off of the scale that we're providing them. Then the clinician does what clinicians do. You try to decide what could potentially be the cause of these things. Once you rule out all the causes and you feel like it's a medication, then you look at the biomarker results. Maybe it's a double negative that gives you a high negative predicted value that there's any kind of subclinical inflammation happening, and then you might be more willing to have a discussion with the patient and talk about what can we do about this, what can we do with your medication regimen to help prevent some of these problems. So getting that patient-provider relationship more involved in helping with clinical decision-making. And maybe it's not a double negative. Maybe they have positive tests, and then you still have that conversation with the clinician the conversation with the patient to explain to them what the risks are and what's going on. It really kind of, in my opinion, really helps with the patient-provider relationship, and that's really what our focus is. So not only are we going to be looking at renal function, but we're also going to look at self-efficacy, general overall health, and we're going to focus a little bit on depression. We're also going to be, of course, looking at graft survival, hospitalizations and cause of hospitalizations, and then change in provider satisfaction. And it's called provider satisfaction, but really the questions are more focused on how confident you are in your decision making, as well as, we use a couple of questions that are highly correlated to burnout to make sure that, by giving you more information, that we're not just giving useless information that then causes more burnout, because that's what happens with us all as clinicians. We get more and more stuff, and then it becomes harder and harder to do our job. Other trials that we have coming up in the next several months are one targeting on non-adherence. So we're going to be following subjects, approximately 1,000 subjects for 2 years who are getting regular biomarker results. They'll also be providing self-reported non-adherence assessments. We'll also look at some clinical factors that are tied to non-adherence, like tacrolimus, IPV, missed clinic visits, poor control of their comorbidities, and tying that back and seeing if there's a relationship between the omnigraph biomarkers and non-adherence. Not only if there's a tie between non-adherence and the biomarker, but also as it changes over time. Does the biomarker results change over time? Is this a tool that can be used in an entity, non-adherence, that is very difficult for us to find in our day-to-day practice? We'll also be opening up the TrueLow extension. So as part of the TrueLow study, it was already put into the protocol that there's an opportunity to extend the study follow-up for 2 years. And so those sites that are involved with TrueLow will have the opportunity to keep their patients in it for another 2 years, so we can then see additionally the relationship between biomarker results, time on biomarker, with most of the clinical endpoints that we're already looking at in the TrueLow study. And then finally, SURVEIL. This is going to be our randomized multi-center trial. We're going to test the clinical utility of integrating serial biomarker monitoring into clinical practice in order to help guide the selective use of biopsies, monitor patients, and titrating immunosuppression. So this is going to be, and it's going to be compared to standard of care. This is going to be, I think it's going to be one of the most exciting studies that we have opening up, and I think a lot of people are going to agree once they start to see this happen. So a lot of great things happening and a lot of information that we're going to be providing you in the years to come. Again, right now I get to deal with the hope and dreams a lot, so I hope and dream that we're going to have some really great outcomes to provide to you guys in the next few years. Now I'm going to talk a little bit about I'm going to wrap it up with the liver clinical trial before we get to questions. So you guys got to see a lot about the problems in the development of the TrueGraph liver, as well as the TRAC liver. Well, you didn't talk about it as much, but it did happen. TRAC, our donor-derived cell-free DNA product in liver transplant. And so we wanted to early on to get into the realm of how to use this biomarker. So the clinical, not only the clinical validation that's already has occurred, but also now how can it be used within clinical practice to help target some of the problems that we face. So this is a 12-month study that has approximately 10 transplant centers in it. 130 patients are going to be randomized either into a control group or a study group. The study group gets their biomarker results monthly for the first 6 months to help aid in immunosuppressive reduction. The control group does not. They have the labs drawn, but it'll be analyzed at the end of the study to look for associations. And we're really kind of looking to see how many of these, is there going to be a difference in patients receiving the biomarker results that can achieve a lower immunosuppressive, so a greater immunosuppression reduction in a safer capacity. We'll also be looking at a lot of important secondary endpoints, including renal function, some of the problems that were discussed in the preceding presentations. We also have a lot of data that we'll be collecting on comorbidities and the control of comorbidities during the follow-up time to see if we see any differences between patients in the study and control group. So we're really excited to, we're really excited about the study, and it's enrolling really quite well right now. So this is an active clinical trial. And I think that's it for me. Oops, did I push the wrong button? Oh, I have an announcement. We are going to be having a dinner February 24th, which is tomorrow, 8 o'clock. We're going to have a great speaker, a person who I've really enjoyed every time I talk to. Dr. Fouad Shihab is going to be giving a discussion on OmniGraph and his experience with it. It's going to be at Dominic's Steakhouse. I'm going to leave. I was told that I should leave this up here so you can use your phone to scan that and RSVP, but you're all welcome to come, and we're really looking forward to seeing you there.
Thank you, everybody. Thanks for joining us, and thanks to our wonderful speakers here. We do have Erica walking around if anybody has any questions for our speakers. We do have a few minutes left. I have a question for Dr. Petty. So I know we talk a lot about the utility of these biomarkers for the clinician, but you are now working with patients and these results that you're using kind of real time. What kind of feedback, or if any, have you received from patients on the results, how they feel about them, how it's utilized in your trial?
The patients are very excited about the study, actually. So 100% of the patients agreed to participate in the study, and patients are doing very well. I mean, lower immunosuppression means that, we have had fewer hospitalizations, fewer side effects. I think they're doing very well, and they're very happy about it.
Awesome.
We have a question. Hang on.
Well, great presentations. Dr. Petty, I'm especially interested in your study. I know you had small numbers, but what we try to do with transplant patients is avoid BK virus, polyoma, and CMV from over-immunosuppression. Even without over-immunosuppression, we sometimes see these problems. Did you notice any of these problems in your patients, both the study group and the control arm, and also any thoughts of extending the study to higher immunological risk patients? Because that's where I think will be the higher utility of this. We've tested it in low immunological risk patients, but any thoughts of, or any experience with using it in high immunological risk patients?
We haven't, and two things. One is, we are excluding patients who have BK viremia at 3 months, but we have seen some BK virus infection, but more of BK viruria rather than viremia. So I don't know whether that is just shedding of the virus or whether they really have an infection. It's difficult to say, but we have not seen any BK virus nephropathy or significant viremia. So, and also the second thing is that the general infections like the CMV and all those also are less. I mean, once we complete all of the enrollment and complete the follow-up, then we can evaluate those. Right now, I think it looks very good. So it is possible that you can use this study also for higher immunologic risk patients. For example, I mean, if you look at the BK incidence of BK viremia, that is so high in African Americans compared to non-African Americans, and that is probably a place to use this to kind of reduce the infection rates in those patients.
Thanks for the talk. Just with respect to the way we use this in kidney transplant, and we are just reporting one-time TX, let's say we have a possibility of 3 rows of tests that are normal, and the 4th is positive. It's difficult to know where the problem has started because we are just reporting this as a hard number. Is there a gradient or a continuous variable that could be monitored with respect to the gene expression here that even in those scenarios whereby it is being reported as excellent transplant, that can help us decide before we wait till the 4th month when it eventually turns turns abnormal. The second thing is with respect to infection. Like you rightly said, where this may become much useful is in patients you are reducing immunosuppression significantly on. Have we looking into how this may play a role to determine when we can go up on immunosuppression to prevent rejection? Because obviously that's what we are also trying to avoid. Thank you.
For your first question, I think, unless there is a clinical reason, if you get one non-TX, I usually wait for the next one. And if I get a second or a third non-TX and I intervene by doing a DSA and also a biopsy. And luckily, up to now, I only had one patient, and then that patient did have a DSA, and there was some infiltrate. It wasn't significant for a borderline rejection, but there was definitely infiltrate there, and it was touching on being significant for borderline rejection. So I think, depending upon your risk threshold and risk status of your patient, I think, if it is more than 2 non-TX consecutively, I think, that could be a signal to intervene. Your other question about, sorry, I forgot your second question.
I think the question is much more about those who are consistently having TX, normal transplant function, stable immunosuppression, compliant patient, and by maybe subsequent 4th testing, turns negative. How do you know if that problem has not started a couple of months before the eventual negative, or abnormal test rather? Since we're only having a hard number that says transplant excellence,
Correct.
Is there anything we can track, so to say, to get us to where it becomes abnormal?
Right now, you don't have a number, and right now you only get a binary, but I'm hoping that in the future you would have, like, how abnormal is it? Is it mildly abnormal or grossly abnormal? So hopefully you may have more information on that, but right now you only have a binary, and what we are going to do after the test is continue to follow these patients and just continue on the lower immunosuppression, and only if they have a non-TX intervene and maybe go up on their immunosuppression.
So the potential quantitative aspects are definitely something that is an active research question for us now. Just to give you a little bit of an idea of what we actually report now, it's based upon a probability score. And of course, that's not the same as severity, which I think you mentioned in your question. So the current algorithm is developed with that in mind, but certainly we have an active program to look at the quantitative ability, because that is, I think, an important question as well. Thinking of simply as viral load. Do you have a little bit of BK or a lot of BK? And so having that same process in place would be an advancement of the field, we believe.
I think last question?
Yep.
Thank you for the talk. Congratulations for that excellent study. A couple of questions on the study design. I'm Asif Shah for the from Indiana. Did you follow DSS periodic, like throughout the course at the same time as the true graphs? And secondly, any thought about maybe doing protocol biopsies at time intervals or at the first change when you saw a negative result? Because that would be a bit more convincing and perhaps conclusive that the signal you're getting is correct or not. And then similarly, you could have probably caught some DSS earlier on versus waiting for it to turn negative.
I'm going to answer the protocol biopsy. The whole point of doing the study is to avoid protocol biopsies. So I think, this is a more, in some ways, a for-cause biopsy is what you probably need, is like, whenever you have, I think one non-TX, I'm not sure could be because, the negative predictive value or the predictive value for the test is like about 80 to 85% or maybe 90% in some studies. So I think, if you to have your chances of finding something abnormal on a biopsy is probably going to be more if you wait for 2 consecutive tests at least. Because once again, the numbers are small, but if I had done at one abnormal test, I would have had biopsied 10 patients. If I waited for 2 abnormal, I biopsied 1 patient. So once again, I think this is all we're learning from it. And right now, I think if you just knee-jerk is biopsy at 1 abnormal, you're going to be doing a lot of biopsies.
Yeah, I think instead of for cause, it's more like a biomarker prompted biopsy versus a for cause for a clinical finding.
For cause for abnormal biomarker.
Right.
Yeah.
Awesome. Well, thank you so much for attending. Thank you to CEoT for giving us the opportunity to provide this information to you guys. And if you do have any other questions, we'll kind of hang out up here. If you feel free to come up and ask. Have a good rest of the conference.
Thank you.